I want to also say to you, I hope you and your families are well and safe in these very difficult and trying times, and particularly difficult for you as medical students, a bit amputated from what you are what you should be regularly doing. But I suppose we all have to adapt to this new situation. So I'm not going to read every word on the slide, so you have to read. I don't mind taking questions either on the chat that Aminat is going to read out, or just jumping in and asking the questions. I'm sometimes going to ask you guys questions, so I want you to be involved in the discussion. Whoops, why can't I change my, here. Some of you read, any of you read, everybody has read Charles Dickens. Everybody knows about Charles Dickens. The Best Tale of Two Cities. If not, you should read it. Best of Times, Worst of Times, Age of Wisdom, Age of Foolishness, Epoch of Belief, Epoch of Incredulity, Spring of Hope, Winter of Despair. Sort of about what we're going through now at this time, right? I can't seem to change. Oh, here we go. So, you know, when I was first asked to do this about accessibility and equity, I was thinking of how I would prepare it, and then COVID came along, and I thought this would be an excellent time to reflect on our healthcare system, of the good and the not so good of our healthcare system, of what we're learning from COVID, not the particular specific COVID-related actions, which are very important, but more from a more global policy point of view. So the first thing we can say is there's a lot of positive things we can see, and it's striking, you know, and we have an excellent and easy comparison just looking south of the border. But for example, how our federal and provincial governments and political parties, except for a few exceptions, have put aside their political differences to work together. They're supporting each other. Alberta's even sending resources to other provinces, and they're demonstrating and communicating unity. Decisions are being made on public health council, drawing upon evidence and best practices. And the population has generally followed and accepted the advice and instructions. There's been the appreciation of by the population for healthcare professional workers. You know, when you think back about 6 months ago, doctors were vilified and severely criticized, and now they're treated with great respect and even sometimes as heroes. And healthcare professionals and workers have generally responded with determination and self-sacrifice. And we've seen new innovations developing that we've been thinking about and that would have taken years to implement. And these new innovations are being implemented very rapidly. So how can we understand this? How can we understand this positive aspect? Well, I think it's linked to our universal single-payer healthcare system, and the fact that not only it's a universal single health, because it's not the only one in the world, but it's based on the fact that health is a social and societal value and not a market value. The other thing that each province is really one big healthcare system. So it's able to mobilize resources, plan and allocate fairly simply. And from a medical perspective, there's clear hospital structures and responsibilities and strong primary and community-based care. So this is, read some of this because this is from the New York Times, end of April. Wealthy private hospitals, primarily in Manhattan, have been able to marshal reserves of cash and political clout to increase patient capacity, quickly ramp up testing, and acquire protective gear, compared to a publicly funded university hospital, actually the Brooklyn University Hospital, which had to depend on very small donations, and where somebody said, why shouldn't an African American have facilities that are the same level as other patient populations? It's striking that we would never think of that situation in Canada, in Quebec, where there's two hospitals, one extremely rich and one extremely poor. Yet all is not perfect. All is not perfect. If there are any questions, don't be shy to jump in. Any questions on the chat? Aminata?
Not yet. We don't have any questions yet.
Okay. I realize this is after lunch, and I remember as a student, and still now, you know, lectures after lunch are a great challenge to keep awake. But I'll accept that challenge to help try and keep you awake. So all is not perfect. And without going into specific decisions and actions, the initial strategy to protect the acute hospital structure seems to have worked. But we have the deplorable, tragic situation of older persons in nursing homes and assisted facilities. So first of all, let's say that it's not surprising, and I don't know if any of you, have any of you been to a nursing home, a CHSLD, Centre d'Hébergement de Soins de Longue Durée? I mean, I can't see you picking up your hands, but
a lot of medical schools or medical curricula require us to do volunteering or work in the CHSLDs.
Right. And depending, thanks for that. And depending where you are in your curriculum, in which year you're on, you might have had exposure or not. But so, you know, this is something that I've looked at. I was the author of the Quebec Alzheimer Plan in 2009. And we guesstimated then that the life expectancy of somebody entering a CHSLD was about 18 months. And the people there, generally over 85, have multiple chronic diseases, severely dependent. Almost all of them have some form of dementia. So they're really end-of-life institutions for older people, vulnerable, depleted in many ways. And so it's, and with a high death rate normally, so it's not surprising that when they get COVID, that they high level of mortality. But what's striking then is the fact that the virus spread so rapidly that the staff is overwhelmed. And what's heartbreaking is to see older people living and dying in unacceptable conditions, and dying cut off from their families and being buried alone. Put a parenthesis here is there are many older people with that level of vulnerability who are living at home and receiving some sort of form of home care. And I'm just worried about a similar crisis that is invisible compared to the crisis in the CHSLD, because they're dispersed and living at home. So why is it not all perfect? Well, first of all, this is, you know, yes, we could have anticipated a bit earlier, et cetera, but there's a rapidly expanding, massive health societal crisis. But there are other reasons that are, and that's what I want to get to the heart of what we want to discuss, and it was linked to the original question that was put to me about accessibility and equity. And there are several other reasons that I want to discuss with you. And one is that our universal and comprehensive healthcare system is less universal and comprehensive than it should be. And the other is linked to government policies around financing and organization and management. I'm going to start with the first question, and the question of our less than universal and comprehensive healthcare system, or less than it should be. So, anybody know who this is? Okay, I'm surprised. Nobody knows?
Yes, someone answered Kiefer Sunderland.
Kiefer Sutherland, right. Okay. Anybody knows who this is? So for just to get back, Kiefer Sutherland is a actor. He was the star of the series 24, and what's the latest one where he plays the president of the United States? Actually, a much more progressive. Too bad he wasn't president. I forget the name of the series, but a very famous actor and very successful TV series where 24 is he plays this CIA agent type. So who's this person? Harder, eh? Anybody get it? If anybody gets it, I'm willing to give you your MD diploma.
Someone answered Billy Joel.
No, you're not getting your diploma right away. You're going to have to go through. Okay, nobody? Last chance? Last chance to get the grand prize. Get your. I'll come right away to your house to deliver your diploma, your MD. It's Tommy Douglas. Anybody know who Tommy Douglas is? No?
Nope.
So Tommy Douglas was the CCF, anybody remember who know your history, CCF, the political party? It was the precursor of the NDP. So he was the CCF premier of Saskatchewan that brought in the first universal Medicare system in North America and in Canada, obviously, in Saskatchewan in the early 60s. So what is the why am I showing these two guys? This actor playing, CIA agents, playing American president. It's actually his grandfather. And the connection is, so who are these two people? And there are no movie buffs here. Who's the guy on the left? Donald Sutherland, who's also a well-known actor, and his first wife, Shirley Douglas, who was both were the parents of Kiefer Sutherland. Shirley Douglas was Tommy Douglas's daughter. Okay, so that's going to be on the exam, by the way. So just a little bit of history. Basically, and what I wanted to show it to you because you're all too young to have lived through a context where basically all medical care was through out-of-pocket payments or private insurance. And then you can imagine who was able to pay for it and who was not able to pay for it, who had private insurance, who did not have private insurance. And progressively, we see the implementation of universal health insurance starting with hospital insurance, and then starting with universal healthcare insurance, Medicare, from 1961 to 1972. By the way, massive strike, doctors' strike in Saskatchewan, supported by millions of dollars from the American Medical Association from the South. In 1964, the Federal Hall Commission on Health Services, which recommended the creation of the public healthcare system. 1969-70, Castonguay Commission, and with the creation in 1970 of the Universal Commission, of the Universal Health Insurance. I want to show, and these are the 5 principles: public administration, comprehensiveness, universality, portability, and accessibility. I'm not going to go into any detail. But just to say a little bit later on, we'll discuss what this meant. But really, it was done in that period of the 1960s, where the real important expenses were around physician, medically related hospital expenses. And that's what the universality and the comprehensiveness covered. And you'll see why and where are the breaks or the gaps in the universality and comprehensiveness. This guy over here, I don't know if you can see my pointer, is me in 1970. I was very young then, I was 5 years old. Before universal public health insurance in 1968 as a medical student, I helped create a clinic in a very poor area of Montreal and chose to work there for many years. And this is an article written by the Montreal Star, which was the biggest Anglophone newspaper of the time, and where I was known as the Red Doctor. And I'm just going to show you, because I think it's worth listening for a few minutes. Now just think of this. This is Centre Sud, which is now where we call sometimes the gay district, which is a little more gentrified now than it was then. It was extremely poor. Very poor housing, many houses without hot water, people on welfare, and the welfare net was not as good as it was then. And very, very poor accessibility to any type of health care. And I can tell you lots of stories. And for many people in those areas, in poor working class districts, this was not even a working class district, it was even poorer than a working class district, but many of these areas, going to a doctor, going to the hospital was mean going into debt. Childbirth for families was going into debt. So I'm just going to ask you to, can you hear it?
Yes, we hear you.
You hear me, but let's see if you hear the sound.
Yeah, we hear both.
Okay. It'll take about 5 minutes. And this was the Citizens Committee that created this clinic, with which I worked.
Ben, disons, Comité citoyen de Saint-Jacques, ça a commencé par un animateur social qui était avec nous autres.
Our Citizens Committee
Travaillait avec des groupes dans le quartier.
was begun by a community organizer who had worked in the area and knew its problems.
Avec des gens du quartier, il a convoqué une réunion générale.
He called a general meeting.
Ils sont venus, il y avait environ 75 personnes.
About 75 people came.
On a discuté des principaux problèmes.
We discussed our major problems.
Les gens, ils ont pensé que le problème le plus urgent, c'était la santé. Puis à partir de ça, ben...
and decided the most urgent one was health care. So we sent a brief with statistics to the governments in Quebec and Montreal, asking for a medical clinic for Saint-Jacques. Quebec ignored us, and Montreal said we had all the hospitals and clinics we needed.
Et puis à partir de ça, ben, on s'est tout organisé pour monter la clinique.
So we got together to organize a clinic. It was difficult because we had no money, but people lent furniture and equipment, and that's how we were able to set up the clinic we have today.
Qu'est-ce qu'on fait? Qu'est-ce qu'on fait?
It came to a point where I couldn't take at all the way it was, the way I was expected to practice medicine as a student even. in the setup of the big hospitals here. Le patient est un instrument de profession. Il est un instrument finalement.
The patient in a hospital is just an instrument for the doctor. That's not at all how I imagined medicine would be when I started.
C'est ça qui m'a amené ici finalement, parce que je me suis rendu compte que je ne pourrais pas fonctionner en médecine.
I couldn't function that way.
J'étais sur le point de quitter.
I was on the point of quitting medical school.
Je trouve ça tout à fait dégueulasse d'être obligé de parler d'argent quand tu fais de la médecine.
I think it's awful to have to talk about money when you treat patients. I've always dreamed of a system where I could practice medicine as medicine, period. Treat patients because they're human, because I want them to be in better health, physically and mentally.
But more than that is, we didn't simply want to get involved in some charity affair, but rather it had to have a political framework.
I came here for one reason, because this was a clinic that would be organized by the people of the area. For the first time, the people of an area would get together and would organize a clinic, and we would come in as workers.
And we were hoping we could set up a type of thing where we work together, many disciplines, in a democratic manner.
Est-ce qu'on est au-dessus de nos affaires ou est-ce que...
Si on paye nos dettes, on est en dessous.
Si on payait nos dettes, on serait endettés. Mais comme les créanciers ne nous harcèlent pas trop,
pas encore.
Il n'y a pas de difficulté, enfin ça marche.
C'est impossible, une clinique comme ça qui existe.
We know it's impossible for a clinic like this to solve all the health problems in Saint-Jacques. What's more important is its role in politicizing people. I didn't come here to be involved in politics. I came here to practice medicine in a setup where anyone who needs it can get the best medical care that exists today.
Comment est-ce qu'on voit la chose évoluer dans, je sais pas, 6 mois?
Where do you think we'll be a year from now?
On devient
Will we become a big Mayo clinic? Or will we have a lot of small clinics in Saint-Jacques?
Ou encore, est-ce que on va se limiter à une clinique pour prouver?
Or have we already proven what we wanted to prove?
Voilà, ça c'est exactement la question que moi je me pose.
That's my question. The clinic exists because of our enthusiasm and our willingness to work for free.
Ça marche pour l'instant. Ça va durer combien de temps? Ça, je ne le sais pas.
I don't know how long that will last.
Pour trouver d'autres médecins, il faut ouvrir la porte qui vient ici.
I think we have to fight to find other doctors who will work in other clinics like this, in other areas of the city.
We're ultimately very limited financially and in terms of power within the medical system. And I think ultimately the difficulties are going to be when the citizens not ask the medical system, but demand of the medical system control of what's going on, because after all, what we're doing here is completely outside the medical system. It's sort of in our own little pocket, and it's going to come to a point where I think there's going to be a clash.
We have a medical school here, or we will have. That's not a daydream. The foundations are already laid.
L'objectif d'un comité citoyen, ça devrait être de former des milliers de cliniques de gens.
The goal of the Citizens Committee should be to form thousands of clinics like this one.
So this was taken 1969. I was a fourth-year medical student. And the person sitting on my right who spoke right at the beginning was Dr. Vanya Jimenez. She was a second-year medical student, but I would go down there as a fourth-year medical student in my first year of residency twice a week. We start about 7 in the evening. We finish about 2 in the morning. This community did not have access to primary medical care. In fact, this project came about because a child died because they couldn't get a doctor to come to see him, etc. Just to say that, you know, before we go on in the critique of our healthcare system, we've come a long way. And that's one of the reasons I wanted to show this, is we have come a long way. All these communities now have Groupe de Médecine de Famille, GMFs, they have CLSCs, they're served by hospitals. You know, that we can make a discussion about the equity and accessibility that is different from all sorts of points of view, but we have the strong public healthcare system for all parts of our society. I wonder, before we go on, if there are any questions or comments about what you just saw.
There are a lot of comments in the chat.
Yeah, how can I
saying,
get to that?
At the bottom of your screen, there's the chat option, or I can read them to you.
Yeah, go ahead.
Such an interesting and inspiring piece of past. Thank you for sharing. Absolutely inspiring. This is so inspiring. Totally. That was so amazing and inspiring, and so on.
Okay. And it was inspiring to me, and I went on to work there full-time as the only full-time doctor, because the other doctors are people you saw. You could see some older doctors in the discussion. They would come in once a week, once in 2 weeks in the evening for 2-3 hours, 4 hours. I became the first full-time doctor. If anybody's interested, these were just excerpts. I'm happy to send you the link to see the full video. It's also fascinating from a public health point of view. We organized, for example, vaccines for measles, and we were criticized by the municipal and provincial authorities for that. So you can see we organized health clinics for workers who are on strike, workers who were suffering from lead poisoning because of their working conditions, workers in pharmaceutical industry, for example, who were developing gynecomastia when they were preparing the estrogen pills.
We have some questions.
Yes.
Does this clinic still exist?
No. So this clinic existed. So Medicare came in officially in Quebec in July 1970. There was a strike, by the way, of the specialists. And this clinic continued for a while as an independent entity. Actually, I was there for 4, 5, 6 years, very full time. And then in the 80s, even more than 4, 5, 6 years, even the 80s, it became integrated into a CLSC. And because it wasn't sustainable from a financial point of view. And then it sort of lost its character, its personality.
And someone's asking, how long could the clinic run without a public funding?
Well, it ran on a shoestring without public funding. So without creating too much mythology, pharmaceutical companies and representatives would give us lots of samples. So we give actually we were able to give for free basically all the medications that the people needed. People were charged, it was a cooperative, $2 per month per family.
Oh.
One of the ways we funded it is either through donations, and then when I started practicing, most of my earnings from the RAMQ went back to the clinic, and only a small part came to me. And all the doctors, the part-time doctors who came like one evening a week, 1 evening 2 weeks, 100% of their RAMQ earnings went into the clinic. So that's how it was funded. But it was hard to maintain. You know, it maintained actually for very strongly that character about 15 years, up to about 1985-ish or so, 1983, 85. There's actually a book that's been written on it. for those who are interested, eventually I can share it with you. But it's a fascinating era. It wasn't the only one. There was one in Saint-Henri. They were called Cliniques Populaires. And they were very much linked with left-wing political movements at the same time. This is the end of the 60s. 1970 was the Crise d'Octobre, which was about at the same time as the doctor's strike around Medicare. So it was a tremendously dynamic, turbulent time.
Yes, and many people were interested in having the link to the video and also to the book. So you can send it to me after and I will share it with them. And I had 2 more questions, but I think you answered part of it. So were the doctors somewhat remunerated, and how did you guys manage to get enough donors to make it partially sustainable?
So at some point it was really the income from the doctors. So the doctors who worked full-time, because I was alone full-time, and then a group of doctors, mainly from U of M. I was from McGill, and Dr. Jimenez was from McGill as well, but then a group of a few doctors, 2 or 3 or 4, started working full-time as well. So we all earned much less than what we brought in through RAMQ. So that was a source of income. And again, as I said, the doctors who worked just part-time, like who came one night a week or 1 to 2 weeks, they gave all their earnings, RAMQ earnings. And then we got donations. There was this dentist, I'll never forget his name, Cyril Flanagan, who had born and raised in Point St. Charles, a very poor area, and then became a very successful dentist. He donated dental equipment. He brought in dental students from McGill. So it was things like that. And then there's the medication that came in as you know, huge numbers of samples, more than the usual small samples that they give to doctors' offices. So we were able to sustain it that way. But it's, as you can imagine, it was haphazard a bit.
And how could the doctors in the clinic manage their own living if they were spending their earnings to maintain the clinic?
So the doctors who work full-time drew a salary. Okay, so all the money, for example, like my case, all the money from the RAMQ went into the clinic, and the clinic paid me a small salary.
Okay.
Very much less than what I brought in. That was my choice. And actually, in a discussion with the president of the FMOQ that day, he yelled at me and he criticized me for doing that.
Okay, and did the government knew anything about the clinics?
Yes, yes. We were functioning on, there was nothing illegal with what we were doing. Perhaps giving out the medication, that was, you know, ça frôlait la légalité, because doctors are not, but we didn't sell the medications, we gave them. But otherwise, it was a doctor's office for all intents and purposes. And, you know, we were good physicians. We had specialists who came in. One just died last week, Dr. Henri Bellemare, who is the head of internal medicine at Sacré-Cœur. So we had specialists. We had surgeons, psychiatrists, we had dentists, pediatricians. So it was actually, that's where I learned my family medicine.
Okay.
As a student and resident, because my residency was actually a residency in first, what was called a straight internship in surgery.
Okay, thank you so much for your answers.
Shall we continue?
Yes, but before, I think someone raised their hand.
Yeah.
I don't know if you want to ask your question.
No questions at all, no questions.
Okay, perfect. So you can continue.
Okay, so I think it's important, and again, because there are many reasons to criticize our healthcare system, but there are many reasons to appreciate and celebrate our healthcare system, and where it's come and where it's allowed us to come in, and even where it's allowed us to react to this terrible crisis that we're in. So so I'm going to come back to my question is, and the idea of this, we have made progress, okay? But remember, my question is, why is it not all perfect? What happened? So now that I've said we've made progress, I want the criticism of our healthcare system, but I put in that context is, one is we don't really have complete universal coverage. We have universal coverage or comprehensive coverage for hospitalization and medical services. There's no out-of-pocket payment. You go see a doctor, you don't take anything out of your pocket except your Medicare card. You get hospitalized, you don't see anything out of your pocket and get medical card. And I'm going to tell you another story. Do I have time? I can go on and on and on. How much time do I have left?
You have 15 minutes left.
15?
Yes.
Okay. So I'll tell you another story that has remained with me all this time. And I was already a geriatrician at that time. I was doing consults at the Royal Victoria Hospital. And the first patient I went to see was a guy, a worker from Hochelaga Maisonneuve. Most of you, I hope, know where Hochelaga Maisonneuve is, the east end of Montreal working class district. He was in a private room because he was sick and he needed to be in a room by himself. The next patient I went to is a patient that lived on one of the wealthiest streets in Westmount, which is the wealthiest city probably in Canada. And I looked at her husband, I looked at her name, and I said, was your husband a president of one of the biggest banks in Canada? And she said, yes. And this lady was in a 4-bedded room because she didn't need to be in a single room, and she was recovering from hip fracture surgery. And it struck me, that's our Canadian healthcare system. So we do have hospitalization medical services. And when it was created in the 60s, that's what people wanted to cover. They wanted to cover going to see the doctor and going to the hospital. We didn't think of aging and chronic disease. And so what the community home care services, institutional long-term care like the CHSLD, and even medication were not part of it. And they're sort of universal but selective, a mixture of public, private, and co-payment. I won't get into the details now. And they're sort of in and out of the healthcare system. And there's always been an ambivalent and ambiguous relationship with the private sector. So on the one hand, we have the publicly managed and publicly run CHSLDs, like, for example, Maimonides that you might have gone to, or Elder Care. And then you have different types of private CHSLDs, which we've heard a lot of criticism about in the past weeks, but are used a lot by the public healthcare system. In fact, what the public healthcare system does, it rents beds, rents in quotation mark beds. It sends patients that the public system pays for to be in a private bed, because the public system has limited the number of beds that they've created in CHSLD. In fact, with the rising aging population, they've actually reduced, from a cost point of view, they reduced. And so now we're criticizing the private sector, but we've been filling their beds, not all of them, but giving them a lot of patients in their beds, paying for them. So you know that the sources of our financing is basically taxation, and 70% of costs in our healthcare system are covered. But out-of-pocket or private insurance has to cover dental services. I mean, why would dental services not be covered? Why is the health the mouth, not as important as the health of the other end of the digestive tract, which is covered, right? It's a bit of a silly example, but it's not so silly. How dentist is oral health is so linked to nutrition. Most outpatient physio, assisted living, etc., occupational therapy.
Mati raised his hand.
Yes.
Hi, just a quick statement. So dentistry is not covered anywhere. I think Canada is not alone in this. Countries like Sweden, Norway, Taiwan, even San Marino, Italy, dentistry has never been covered, I think. It's a pity, but
no,
that's
actually covered. It's actually covered in many European countries.
Yeah, in Germany, and
not just in
Austria.
Germany, but in many European countries. But the fact that it's covered or not, it still raises the question of why it's not covered.
Right. Yeah. Thank you.
We're certainly not alone. I agree with that, but there are certainly many countries who do cover it. So, what's happening in terms of financing now in organization? I'm going to go into that. Is the result of government policies for many, many years, and by all governments, and accelerated in Quebec under the previous government. I won't mention Barrett's name. So let's look at financing. So you might have all heard that we're constantly worried about the fact that the percentage of the provincial budget is increasing for healthcare. But in fact, if that is true, but at the same time, funding has not kept pace with demographic and healthcare needs. And one of the problems has been there's been a major decrease in federal transfer payments to the provincial governments. So yes, a higher percentage of the provincial government is for health, but in absolute terms, it has not kept pace. Not kept pace with the health needs. And in some years, it's just keeping pace with the cost of living. The other thing that strikes me is that budget from a human material and resource planning, healthcare expenses, is basically what is the minimum necessary to run the healthcare system. And I get it, that it's a budgetary point of view. But you know, we're always running at 110% capacity in our hospital beds. The medical manpower is counted right to the decimal point. You know, the prems for family medicine, the number of specialists per hospital. And recently, several years ago, we saw a 30% cut in the public health budget. And this has been even more so in home care and CHSLD. And think of the pathetic debate about increasing the number of baths per week, which was 1 bath per week in a CHSLD. It's pathetic for people who are mainly very, very limited mobility, many incontinent, fecal and urinary point of view. CHSLD buildings are obsolete. And then, as I said, well, I didn't say, but the recent rapidly increasing COVID cases in Montreal's poorest and very populated neighborhood brings to mind the recent 30% cut in Quebec's public health budget. When I say public health here, I mean la santé publique. So Arruda, who leads the santé publique, his whole, from right down into the regions, that was cut 30%. And now we're running around like madmen to try and say, how are we going to develop testing and following people who are positive in places like Montreal Nord. There's the notion that the healthcare spending is an expense. It's a socially necessary expense, but not seen as an investment. So we say, oh, it's 49%, it's like flushing money down the toilet. And we rarely consider the healthcare system as a source of employment, and in many cases, high paying and very high skilled jobs, innovation, research, new industry startups, you know, think of the MUHC, the Jewish General, with these very important research centers, the spin-offs of companies that's created out of the research, etc. So it's actually a very dynamic part of our economy, but it's not considered that way. And then there's the question of organization. There's been excessive centralization progressively, and this, again, it's all governments, and it's all governments, and again, accelerated by the last one. Excessive centralization, micromanagement. Everything is decided at the ministry level, and a top-down approach. And with the massive mergers with the creation of the CSNCUs, communities, patients, and healthcare workers have been disenfranchised, disengaged, loss of identity. And what's happening is these massive structures. I don't know if any of you read La Presse Plus on your iPads, on your iPads or whatever that you have. You should get it. I hope you guys read newspapers. But there was a whole section today of people demonstrating how slow and bureaucratic these massive structures are in reacting to the crisis. You know, before, and I'll take the example, I happen to know it, Maimonides, which is a CHSLD, you know, they had their own executive director, they had somebody responsible for ressources humaines, for finance, etc. Those people were there, they were on place, they could react, they could move. They were very much linked to the community. We've lost that. The Economist, which can't be called a left-wing publication, had an interesting article on the development of universal healthcare, even in low and middle income countries. And just you can read there why they think universal healthcare is important. And how universal healthcare is important because people want to be in good health, and we want people to be in good health. But from an economic point of view, if people are sick, then they can't get to an education, they can't be productive at work. And they indicate, you can read it there, how universal healthcare is pro-economic work, pro-economic growth. We've also discovered, isn't this interesting, in this crisis, how a strong healthcare system is an essential element in the protection of our entire economic and financial system. And again, just compare what's happening south of the border. And this is something new. And just go back to what I was saying about there's no marge de manœuvre, there's no margin of maneuver, there's no reserve. Margin of maneuver is actually related to this notion of being able to have enough resources when an unexpected crisis comes. So we understand that now, which is very interesting. It was never seen that way, that it's a protective factor for our entire economic and financial system. So, in conclusion, I think after the crisis, the population is going to expect that we draw valuable lessons from this experience. My concern is there's going to be a plethora of committees, commissions, and they're all going to look at, you know, what happened in CHSLD, what happened in the testing, what happened here, what happened there. There's going to be, I was going to say hundreds, that's probably an exaggeration. Tens of investigations, parliamentary commissions. But I think what we need to do is to be able to take a step back and say, what have we learned from a policy point of view about our healthcare system? And I think we have a unique opportunity to organize serious and transparent and public discussion. In the year 2000, I was a member of the Clare Commission. I'm not sure if any of you know what the Clare Commission was, but it was a royal type commission set up by the Quebec government. The Quebec government set up one in 1969-70 with Castonguay, which led to the creation of the Medicare system in Quebec. In 1985, 15 years later, led by Rochon, which led to regionalization and ambulatory care. And 15 years later, in 1999-2000, the Clare Commission. And I had the honor of being on the commission. And my baby on that commission was the creation of the Groupe de Médecine de Famille, the GMFs. So each commission brought public debate and public discussion and led to very important changes. And we haven't had one because Barrette considered in 2015 that he didn't need any advice. But we have an opportunity now, I think, to step back and see, what have we learned about the fundamentals of our healthcare system over and above the COVID lessons as such? So here's a few central issues. I'm going to end with them. Is healthcare expense promoting high quality care and strong public health is a central issue for our healthcare system, and that there are investments contributing to both the well-being of the population and the growth and protection of the economy. That's a question for discussion, and the implications of that are not simple, but it's a question for important discussion. The second is home care and LTC, CHSLD, as well as community services such as dentistry, rehabilitation, psychology, and social services should be as integral to the public healthcare system as are the medical and hospital services. You know, we're stuck in the 60s and 70s with the conception of what is a medically necessary act. And the third point, I think, which is a very important point for discussion, is a strong healthcare system is anchored in strong local governance with population and community engagement and accountability. Moving away from these huge, paquebot, how do you say paquebot in English? Ocean liners. And if you can, read the article in La Presse Plus today. Just a word for you guys, upcoming physicians. The role of physicians also has changed, or our notion of accountability as physician has changed. In the good old days, I'm being sarcastic with the good old days, the accountability we saw was to the individual patient sitting in front of us. That's all we cared about. So, accountability to the individual patient is necessary but no longer sufficient. And what we're seeing now, and you guys are going to live it more and more, is accountability to the population and to society, as well as the accountability to the individual patient. So, I presume most of you know who this is, or do you? Can I have a name? No? You got to know who that is. Somebody. On the chat?
Wayne Gretzky?
Yeah. So Wayne Gretzky said something very interesting. He said, "I skate where the puck will be." This great sense of anticipation. And that's what we need to think of with our healthcare system. When I was younger and I played hockey, I skated where the puck was. And by the time I got there, the puck wasn't there anymore. And so that's why I went into medicine. So I'm hoping you guys will skate where the puck will be. And he also said something else, Wayne Gretzky, which I very much like, is he said, you miss 100% of the shots you don't take. In other words, il faut oser, you have to dare. So thank you very much. I hope we still have some time for questions. I'm happy to look at through Minata if you have any questions that you think of later.
Yes, thank you for this presentation. Unfortunately, we don't have a lot of time for questions, but if anyone has a question now, they can ask it.
Okay.
Don't know if anyone had a question.
Hi, I have a question actually. Thank you so much for the presentation.
What's your name?
Rosa. I'm a
Okay.
third year medical student at McGill.
Okay.
Thank you so much for your presentation. It was so interesting. And actually, my question is about local governance. So, what can we do to empower communities to take the lead in local governance and actually be advocates for themselves?
So I mean, part of it is to convince the government to reverse at least partly, you know, the massive mergers that went on. And by the way, this is not only Quebec, it's across Canada. So the CSM Island, you know, runs the Lakeshore Hospital used to have their own board. The Sal Hospital used to have their own board. The COCs had their own board. I don't know if they have the Douglas had their own board. They have a rehab center had their own. If we can reverse at least some of that to give back some, and even the CUS boards are really sham boards. So if we could at least, and that has to be government decision, political. So that's political action to change the government. In terms of an area where we can make change without waiting is in many of the GMFs. Les groupes de médecine de famille could put together, ils peuvent mettre sur pied leur propre comité de consultation, leur propre conseil, and with representatives from patients, from people in the community, from workers at the GMF, from clinicians, etc. So we can start to change things, but obviously there's going to have to be changes made by the government itself.
Perfect. Thank you so much.
Okay. Any other quick questions?
No, we have a lot of thank yous in the chat. But
okay.
Mati raised his hand. You can ask your question if it's a quick question.
Hi, just a quick question. I'm a final year medical student from Austria, and
what are you doing next year?
What am I doing next year? Residency in interventional radiology.
Okay, good.
Yeah. So just a quick question. This is a bit off topic, but do you suspect that policymakers might think that private insurance companies might capitalize on the fear factor of people once the crisis has been averted? This has happened once before in World War II, and that's when, you know, there was a boom in private health insurance and so on and so forth. So what do you think, in perspective with COVID-19, this would happen to the private healthcare sector? Thank you.
Yeah, okay, that's a very interesting question, and the answer is a long one, so I'm going to try and make it short. Simply to say, you know, there are two big categories of healthcare system. One was called the Beveridge system, which is based on the English system, the British system, like our system, which is tax-based. And the other is the European, the Bismarckian system, which is based on Social Security. And in that system, there's a much greater opportunity for private or mutuals, whatever you call them, so private to establish. In Quebec and Canada, there's basically very, very, very little market opportunities for private insurance. I mean, I think it's even possible to get private long-term care insurance, but it probably cost a fortune because the market is so small. When I was on the Clare Commission, we had proposed that the government create a government long-term care insurance, and they didn't. And that was unfortunate. So I don't think it's going to be an issue. I don't think that's going to be an issue. I also have the feeling, and I know healthcare systems in many parts of the world. I spent time in Switzerland. You know, if I'm paying my healthcare dollars from my right pocket through taxes, or from my left pocket through private insurance, or from my back pocket through out of pocket, it's coming from one of my pockets, it's coming from me. And whatever way we count private public, it still has an impact on society. And that's why, for example, it's such a problem in the United States, that the percentage of the GDP taken by healthcare is so high. So in short, little chance for a market in Canada. I don't think that's going to be an issue. But thanks for the question.